This will be recorded. I want to make sure that, please make sure that your audio is muted unless you're speaking. My name is Melissa Benson. I'm the project manager over Project BEACN, which is building engagement to address complex needs. I want to thank everyone for joining us today. Today we have with us our consultants from the National Center for Complex Health and Social Needs, which is an initiative of the Camden Coalition of Healthcare Providers. If you have any questions, technical difficulties, or anything, please reach out to me. You can reach me at mbenson@bhnstl.org, or you can chat, whichever is better. Let me go on and pass it over to our consultants, Jason Turi and Lauren Harden, so they can give a quick introduction. Thanks again.
Thanks, Melissa. Hi, good afternoon, everyone. Thank you for joining us on a Friday afternoon, close out your week. We promise to be as valuable as we can, and we really appreciate everyone's time. So thanks for being here. So my name is Jason Turi. Again, super excited to have this amazing group of folks here and to be doing this work in Greater St. Louis. I'm joined by Lauren Harden. I'm Director of Field Building and Resources at the National Center for Complex Health and Social Needs, and that is an initiative of the Camden Coalition of Healthcare Providers. Our focus is on complex care delivery for medically and socially vulnerable, complex, and marginalized populations. So we're super excited to be here. We get the opportunity to work with organizations and consortiums like yourself around the country. And as we said in our Innovation Summit last week, we're thrilled to be working in St. Louis. There's great organizational leadership across sectors, a lot of great work already going on. And I think, as you'll see in our presentation today, a lot of the pieces in place to really build an effective complex care ecosystem for the folks you're trying to serve. So I'll hand it off to my colleague, Lauren, to introduce herself, and then we'll jump right in.
Hi, everyone. Like Jason said, thank you so much for joining us on a Friday afternoon. Both Jason and I are nurses, and we've both been involved in direct delivery for complex populations and for many years before we joined the National Center and helped sites around the country set up the models that they want to create. But I just wanted to say a shout out to IT staff in general. I created a model in the Trinity Health System almost 12 years ago. And my strongest partner in that delivery was IT. We were able to create some really helpful tools together that helped the population, and also data analysis that really helped us understand who was in the most need and how could we target those populations best. So we're really excited to connect with you, hear about the excellent work you have going on, and share some things that we're seeing around the country that might be of interest to you. So I'll turn it back over to Jason.
Thanks, Melissa and Lauren. Next slide, please. So just to talk about how this is less of a kind of didactic teaching session, and we hope to foster exchange as well. And we'll have some direct questions for the folks that are participating on this call that represent organizations from across the St. Louis region. So, but first what we'll do is we'll go through some national trends and updates on some key areas that tie directly to the goals of Project BEACN. And then we'll have a focused discussion on the Project BEACN IT and data goals in general, some updates from the field. We'll be asking you some questions around the technology you're using, your experience with that, use cases, utility. So much of this will be an exchange like that. But first, Lauren and I will open up with a scan of some national trends that we're seeing that tie directly into it. So we're going to start with health information exchanges. Now, many of you might be saying, whoa, we've heard about this before. And we're really here to introduce a topic if you haven't had exposure to it. Also to test out what's the potential utility here of this very powerful tool. So I can speak with some experience about this. In Camden, we run our own, and you can see it here. We made the list here. We run our own regional health information exchange. So we're very much an information broker in the South Jersey region. And we've used this health information exchange to operationalize our complex care programming. So there is potential there. Not all of the health information exchanges have been leveraged like that. But I want to go over the concept in general, talk about some of the opportunities and challenges here. So broadly in HIE, and you can see here from this square schematic, has the opportunity to incorporate various health and even including more social service and even government data sets. And you can see there's many HIEs across the country with various levels of functionality and access. The group that is that would be representative of the St. Louis region would be the Midwest Health Connection. So further on in the discussion, we're actually going to talk about, has anyone used it? Does anyone have access to it? Are folks participating? When you go onto the Midwest Health Connection site, you can actually pull up participating organizations, and many of you might be in an organization that is actually participating. And participating could just mean you're pushing data, or someone in your organization has access to it. But that doesn't necessarily translate to we're actually meaningfully using it, it has utility, and it's having a demonstrable impact on our programs. So, and that seems to be, there are the opportunities and challenges within HIE. For example, in Camden, we use our HIE for event notification. So hospitals are pushing events like ED utilization, inpatient utilization to the HIE, so we can see that when someone in the city of Camden goes across the 3 health systems. They're also sharing clinical data as well. Discharge summaries for one, but also the admission notes. There's actually a growing list of actually notes that are shared from the electronic health records. So there is potential utility to use it to supplement the information you can get on any individual. But again, there's a lot of variability. Lauren, do you want to, I know you had some experience with Great Lakes here. They have some interesting use cases and have really developed themselves well. I don't know if you want to just mention it before we jump off the HIE piece.
Sure. So I had the opportunity of working in Michigan for the majority of my career. And Great Lakes Health Connect started very early in the development of HIEs. We had a very robust system. All of our health systems were on it. What we were able to do with the HIE is collaboratively utilize that to input and share shared plans of care to really save time for providers across systems and improve safety. And then we were able to collectively look at the data that came out of the HIE to identify across the city what were the opportunities. So when we first started looking, we met with all of the health systems, behavioral health, social services across the city, and identified a tremendous process improvement opportunity for how we treated chronic pain from the emergency room. So when we looked at the data, we saw a whole population that had high utilization at that time for really accessing opioids. Things are quite a bit better now than they were then, but there's still opportunity in that area in most markets. So we agreed amongst the hospitals to come up with a shared plan of how we were going to address chronic pain from the ED, and we created an education tool together. So it wasn't just locking people out of getting treatment. It was really educating them about appropriate treatment for chronic pain and then linking them to the right services to get the right pain management. So the tool can be really powerful and start to take us out of our silos and start to help us see, what's happening in our community, what could we potentially do together. How could we help each other? How could working together help us be more efficient and improve outcomes?
Thanks, Lauren. And so there is some potential here, and we'd like to hear more about, and we'll talk more about it further in the discussion about your experience with the HIE. So Melissa, could you just go back just one more on there? I just want to talk about the use case just for Camden as well. Well, and actually we can probably wait. So apologies there. Why don't we just keep it going? Thank you, Melissa. And we can get into that further in the discussion. Okay. So Missouri Health Homes. I put this slide over here from the Missouri Foundation for Behavioral Health, and I might not be saying that right, but the Missouri model has been really a standout model across the country. For a lot of reasons. I know when I was working with a large community mental health center in Indiana, Illinois, Kentucky and in Florida and in Tennessee. Tennessee has their own model. We look to the Missouri model as really something that could be implemented in our service area. And I spoke to the folks that actually administer the program as well, and actually administer the NetSmart Care Manager program. So I think you have a really good model there. I know it's been used to build on the CCBHC model as well. So a lot of innovation in Missouri. And so the question here is, linking to behavioral health homes in the context of Project BEACN, clinically, but also focusing here on the information systems that are available through NetSmart's Care Manager. So many of you have experience with behavioral health homes, and we'll probably be able to talk directly to the functionality here. But there is the potential here, and we certainly want to explore it, of linking to the health home data, which is, again, not, from my understanding, not perfect. But as you can see here, this is significant when we start talking about claims, client level detail from the Department of Mental Health, hospital need RN notification, and clinical data that's put into the platform. For those that aren't familiar with the behavioral health homes, and we can get into it later, the idea is there's a central platform that folks use for administrative reporting functions. Many of the community mental health centers are on their own EMR, which may not be a NetSmart product, but can put information into Care Manager as kind of the central kind of platform to administer the program. So I think there's some potential here. I'd like to find out more about your experience, thoughts on how we can best integrate clinically and data-wise with the health home model, because I think from a clinical perspective, from a performance and evaluation perspective, from interoperability, we can. I think we want to make sure we capitalize on the opportunity here. And I see Sally saying, Certified Community Behavioral Health Organization, CCH. Yeah, so Sally, we should get into that as we open it up around the health home discussion. And some of these terms are new to me. I'm not as familiar with the Missouri terrain. So I think we can probably move forward on this one, unless, Lauren, you have anything to add. No? Okay, go ahead, Melissa. So another component here, and there's definitely an opportunity in Missouri, and we'll talk about it in the next slide. The field is becoming increasingly, I think there's definitely an opportunity here as the field grows with trying to foster interoperability across systems. So there's 4 platforms here, and there's certainly much more than that out there. Here are some of the larger players, and there's Collective Medical, Patient Ping, Care Equality is another framework around interoperability, and I focused here on this, I believe it's a platform, I don't know how robustly it's used here in Missouri, called Epic Care Everywhere. We know the systems that are on this call that are the health systems that are associated with this project. I believe many of them are on Epic. So we want to focus on solutions that could potentially be brought to bear to connect within and across systems. And Lauren can certainly mention this too, Collective Medical, for example, and we'll get into it in the next slide, is a platform that offers interoperability across different electronic health records, especially focused on shared event notification and shared plans of care. The same thing with Patient Ping, the idea of having an event notification that can integrate with your electronic health record or be standalone. That can allow you to know when and where, if your patients or your members or your consumers, right, are accessing other healthcare entities that are tapped into the network. So especially in the context of BEACN, as these complex high-risk individuals are circulating through the care continuum and across the systems of care, how do we know where they are? This presents an opportunity. Certainly, for example, in the HIE on event notifications, if that's functional, that presents an opportunity. So we're going to want to talk about this, and this will lead us into, Melissa, if you go into the next slide. Thank you. Collective Medical. So many of you may have heard this. You might be using it already. I took a little snippet here from the Missouri Hospital Foundation. Excuse me, I hope I'm saying that right. But there seems to be movement in the state around hospitals adopting Collective Medical to support interoperability and communication across systems in a shared plan of care. And I've highlighted what a notification can kind of look like here in the, or the components of a notification in collective medical. So this would be, just to, if you haven't used it before, imagine an integrated kind of single sign-on where you could link directly through your home electronic health system if you're on it, if you're electronic health record if you're a health system, to link to something like this track board here, would show you a list of individuals that are utilizing services again across other providers, and they're able to put some analytics next to that, assign some risk. You can click into this, and we actually just had a demo with the folks at BEACN as well, around shared plans of care as well, in order to foster that collaboration and coordination across systems. Lauren, do you want to add anything here? Your experience with Collective?
Sure. So Collective Medical really came out of HIE Pre-Manage, which started in Washington State, and it was really started really supported by Washington emergency room physicians and a social worker. So they were very connected to the need for some kind of technology to share information about complex patients across systems to really improve coordination, improve outcomes. It was implemented pretty widely across Washington, Oregon, and California. And there's real benefits from it because it can sit on existing platforms, it can pull data from the HIE, and you can enter a shared plan of care with an alert in Collective Medical. One of the challenges is it's only as good as the quality of what you as a community put into it. So if the shared plans of care are not very valuable, people tend to not look at them. So it's really important what effort you put into design if you are looking at adopting something like this. Is anybody on the call currently working with Collective Medical, or would anyone on the call like to add in what their experience has been with Collective Medical?
Lauren, this is Wendy. I'll just jump in real quick. Collective Medical is pretty new, I think, to the state. Several of us, I know at Mercy and through BEACN, we've had some demos with Collective Medical. Really love their product, love their work, but it's also, we're trying to figure out how this intercedes or intersects with the Midwest Health Connection, I think is their new name, and being the state HIE that's out there. So the other thing just to kind of keep in mind is there's discussion through another group that's looking at Unite Us, which is a platform really focused on social determinants of health. And so we've had some preliminary conversations with MHA and Collective to get a better understanding of this announcement, the press release that they had, to better understand exactly how that's working. So I think we're in pretty early stages of it here in Missouri, but kind of excited to see how this and the state exchange and platforms like Unite Us might be able to work together. And I think Collective is in other states actually has an integration module with Unite Us, which is good because this group has been working on this for quite some time and working with many of our community supports on the Unite Us platform as well. So I think it's pretty new.
That's great. We get the opportunity to intersect with all these technologies because we work around the country, and Unite Us is really emerging really quickly as a best-in-class technology platform for really collecting what are all the options for services in a community for different social services and referrals. So instead of that wonderful care manager binder with all the phone numbers, you have one integrated system across the city, and people can add in and adapt that, and you can find information quickly and make referrals to each other through something like Unite Us. The bottom line of why we wanted to go through these different technologies is just to give you an overview of what are we seeing around the country. We have done this kind of work all over, and with starting out with shared plans of care, I've been involved in builds where there was no technology. We did the shared plans of care on paper and people were scanning them into their electronic health record. It is possible to do without the technology, but it's so much more preferred if you have a shared system. And we're really interested in learning from you today about what you have going on, what is working within each of your organizations as we talk together about the next phase of what will be happening as part of this build. Next slide. So I wanted to show you some core components that we've seen be very successful as we've partnered with IT in building these types of shared plan of care systems. And they're integrated primarily in a lot of the technologies like collective medical, but just seeing what those core components are. So first of all, in the system, it's been very helpful to have some type of consult order that can be fired. It's not required, but it's helpful. So for the staff who are going to be implementing the BEACN intervention, for people to be able to enter an order to consult them is very helpful because it's a trigger that you can capture across the city. You can capture data on that, and it gives a way for the team to find out about new cases. In the Trinity Health System, we built this in Cerner. There is a complex care order in the Cerner order set. And the order in the Trinity Health System, we were able to utilize that to order a nurse or a social worker. It was a complex care consult, not necessarily a physician-driven billing consult. It was a notification that this patient qualified for the program and needed intervention. The second step that's really helpful with these types of programs and shared plans of care is a structure around holding a shared case conference. This doesn't necessarily involve an IT component. It involves the people that are directly working with the patient, coming up with a shared story about what's happening with the patient, identifying key components of what you'd like to see in a shared plan of care. And then the outcome of that meeting is entered in some type of shared plan of care structure in the electronic health record. So the shared plan is a component that's very helpful to do consistently across systems. We've also done it like I was explaining previously on paper with multiple different records, but you have some technology in place and coming down the pike that could potentially be used for one consistent structure for shared plan of care. How systems have done it without a technology like collective medical or an HIE, there's often a note section in the electronic health record. IT has adapted the note section to have a complex care note. The team enters the shared plan of care in that note and monitors that plan in the note if you don't have that shared technology. Some of the key components that we're finding helpful in these plans of care: patient information, any warnings or safety alerts. That's often really important with a population, whether they have a rare disease and it's important to know what to pay attention to, or whether they've had a violent incident in the emergency room previously. That's helpful to pay attention to. Or just understanding, the person may have a background of really intense trauma, and how to approach them appropriately is really helpful to see on the front end. And then a summary of the situation, the background, the assessment, and considerations and identification of the shared team working with the patient. Next slide, please. So the IT components that we've seen be really effective, that consult order as I described, some place to enter the complex care note, whether it's in collective medical, which already has this type of screen built in, or whether it's in the HIE where you build it so everyone can see it, or whether it's individually within your health systems record. And then attaching that note to a complex care alert. So some way of identifying when a provider or anyone opens the electronic health record, this patient has a complex care plan, a shared plan of care across the city. that's where you'll start to see real gain. This is an example of the alert that we built in Cerner in the Trinity Health System. Anyone who opened the electronic health record, this alert would pop up. If you clicked on details, it would take you directly to that complex care note, which had the shared plan of care in it. If you didn't want to read it, you just clicked OK and went by it. That you could still see the shared plan of care in the notes section, but most people read it because it was succinct, it saved them time, and it really started to coordinate care.
Lauren, can I?
Yeah.
Sorry to interrupt. Just some clarification on like what this looks like in action. So for the Epic users out there, and Lauren, you might be familiar with this, like for example, very basic functionalities. You can put a flag in a chart.
Mm-hmm.
You click in that and you can write something, and it's on like kind of the face sheet area, depending on what your Epic configuration looks like. And that might be useful at like one instance of Epic at for example, a hospital. When as you implemented this, is this something that when you said across the system, did this go through across multiple hospitals in a geographic location?
It can. This was built in Trinity system, so it went across all 96 sites across the enterprise in 26 states. Mm-hmm. It went to primary care, it went to radiology, it went to urgent care, it went across the whole health system. But the one that we built in the HIE, that flagged whenever anyone opened the HIE. So mm-hmm. Collective medical flags for anybody, who opens that record mm-hmm. across systems.
Yeah, I mean, I think this is good in the context of we're thinking about we have multiple health systems, and we have community providers, and what does that look like to communicate a shared plan of care and having access to this? And I think that's what a lot of these, integrating these solutions in a way that makes sense like that. So this is really helpful. So thank you.
Yeah, and before we had the technology, we literally did it on paper, and the behavioral health provider integrated it in their record. We integrated it in our electronic health record. The Homeless Services Agency integrated it in their record keeping. So it's possible to do without the technology, but I'm a big fan of the power of the partnership with IT and what can potentially be created.
Mm-hmm. Absolutely.
There you go.
So in this section, we're we took about a half hour of kind of intro and scanning the field. So this is really the interactive section. So we're going to, the value of this section really depends on the participation of the participants here. All of you, we're gonna go through some questions here. So you can use the chat, or you can go off on audio as well to explain your perspective. But why don't we go ahead and go through, and these discussions are directly related to the goals, the IT goals of BEACN. So let's dig in on the regional HIE, Midwest Health Connections, and Health Home. So let's start on the Midwest Health Connections. So, and feel free to use the chat or jump off here right onto audio. We're really interested in seeing like is anyone actively using this in their programming? Having not only is your organization contributing data, or are you accessing it for clinical operations? So we'll throw that out there to folks, and feel free to use the chat. If someone's had a really good experience or a negative experience with it, we'd like to know, and this is part of our assessment. Like as we mentioned, there's it really depends on how you're using it, if it is a viable solution here. And then if you have used it, does it have any fields for a shared plan of care? And when I was referring to our Camden Health Information Exchange, our care managers actually document in the HIE. We put our notes there so everyone can see them. So see if anybody has had experience with that on the call. Okay. Again,
I was going to say, Jason, it might be helpful for everyone to enter in the chat your organization and your relationship or use of Midwest Health Connections. That will just help us to get sort of an inventory of who's on the call and what is the adaptation or use of it currently across the US. So if each of you can enter your organization and what your intersection is with Midwest Health Connections.
If any.
You can also unmute and talk.
Yeah, exactly.
Ideally, when COVID's over, we'll be meeting with you in person.
Also, just so everyone knows, Midwest Health Connections used to be called Missouri Health Connections. So some of you may know it by Missouri Health Connections. And I know a lot of hospitals, the hospital systems here in the St. Louis region actually have to or actually provide information through the Midwest Health Connection. And like I said, it used to be Missouri Connection.
Gotcha. And I can just say, as I don't see a lot of, no one's jumping up and saying, oh, I use it. I'm really not surprised. And because, there's a lot of promise with HIEs, but again, participation in usage and utility and incentives to use it, and quite frankly, the functionality a lot of times is suspect. There is potential there though. As HIEs develop themselves, we wanted to keep it here because it is I think it has, again, from national best practice, there is a role to play if there's alignment when it comes to incentive and functionality and integration. So I think we can probably move on. Although, we'll, if one of your partners or if you hear of a use case, it'd be helpful to know of that.
Hey, Jason, this is Sally Haywood. Like back in the winter, Melissa, the Behavioral Health Network does have a license, and we have explored how frequently the emergency room enhancement patients appear in that system, and we explored some of the practicality of it. And if this group wants to pursue that conversation a little more in depth, of course, we would share what Melissa and the BHN staff learned when trying to probe into it a little more.
Right.
But my understanding is some hospitals across the state are using it more rigorously, but very few community providers.
Understood. Yep. Okay. So why don't we move on to health homes? So, sorry, my question for the group here is the potential to link and access to health home data to support this project. And I think Sally, Melissa, Wendy, more broadly on Project BEACN, thinking about ways of, and this came up certainly in our Innovation Summit last week, where folks were interested, like there's the potential to lever behavioral health homes. So I think from a data perspective and a clinical perspective, that's what Lauren and I would really like to better understand here. And I know we have community providers here, and even I'm sure folks that are associated with the larger health systems that have experience with the health homes. So I want to open up on, and it can be a broader conversation on the potential here and the opportunities and potential barriers of working and linking to the health home program in the context of Project BEACN. Okay, so Sally, that's a good point, and I was thinking about this. Is Missouri, is the idea that you have to have Medicaid in order to participate in the health home? I'm not sure if that's the case for the folks that are administering the health home program. And in other health home models, there is money for folks that are self-pay or uninsured or ineligible to be part of the program, so they can be included and data can begin to be captured on them. Okay. So for those that are administering health homes on the call, your experience with accessing data, using the platform that we talked about earlier, I believe it's still NetSmart's Care Manager. It seems to be a robust platform, and there could be an opportunity for a use case here to integrate with Project BEACN. I would think if someone did have Medicaid and they were an individual, so that were serving in Project BEACN, that they would also be in a behavioral health home. So there are some natural synergies that way.
Jason, our colleagues, just as I think the Coalition for Community Behavioral Health Centers, which also just changed their name, that provides support for the use of NetSmart through the healthcare homes. Is expanding that to emergency room enhancement clients, and potentially the next wave would be to expand it to clients who engage with a community mental health liaison, who are staff who engage with police departments to serve clients. So there's potentially an openness to use the NetSmart platform for additional prioritized populations. But in the Eastern region, we've not pursued that because we use efforts to outcome software to do our data tracking on those programs in emergency room enhancement.
Mm-hmm. Understood. And Sally, from a strategic perspective, I see that Barbara had mentioned that apparently for non-medic, that there is, it might be on a case-by-case basis, but for non-medicated folks that don't have Medicaid, that they can potentially be in the health home. And from thinking about strategy and linking in the design of Project BEACN, considering, I'm sure, integrating or working alongside health homes. I'd just like to hear more about how you see the fit happening there, and how you think they can potentially link here so they can complement each other, if at all, or unless you think it's a separate.
No, I think BHN's staff have seen it, anticipated it being a vital component to have our most prioritized super users with complex care needs to explore how we can integrate them into healthcare home initiatives that would be essential.
Okay, yeah, that's what I was assuming. So there's definitely.
Sally, do we need to get Department of Mental Health approval to share that data?
Well, I think it's, I guess I am insufficiently, I'm not confident around what we can share. There's a thick layer of business associate agreements and MOAs and various things for sharing information around ERE clients. But, we'll have to explore what's needed. Wendy, anything you want to add?
No, I don't have anything to add. Thanks.
Mm-hmm. So, well, I think that's probably a question that we want to explore. And so, Sally, just if we think about I want to just dig into the clinical flow here. If someone was assigned to Project BEACN and assigned to a community provider, if they weren't already in a health home, obviously they would be, if they were eligible, they would be linked to that. And that may be a different agency, right? They may be already associated with another health home at another agency that isn't implementing, for example, isn't the initial point of contact, for example, on the inpatient unit for Project BEACN. So there would have to be some linkages anyway there, right? And then maybe some integration, or maybe folks are handed back off to another community health center, right, to enrollment in their health home, right? I'm just thinking about the coordination, and then the data flows after that, the process and outcome data that would be associated with that. So it's something to consider here, and I think there is definitely an opportunity from clinical and data level for integration. And then linking even further here, talking about a shared plan of care between Project BEACN, right, and if someone is associated with a health home, and what that could potentially look like. Where would that exist? I wonder if we have ideas about that. If we can tease that out a little bit, I think that would be helpful. and if someone has found a way with administering a healthcare home with another program and finding ways to foster integration, that would be really helpful as well. Just curious here, how many, if we can provide that in the chat, are there health home providers on the call? If so, could you just add your organization and if you're a provider of a health home? Not sure, we didn't do a check-in that way, but I think that would be helpful. If there is anyone, then we can maybe follow up to do a little bit deeper dive into like health home administration and the dynamics of that, of working across programs. I know it's it came up in our discussion last week. Okay, thank you, Leanne. So we have, so I'm assuming that there's a good degree of folks on here.
Jason, we also might be able to, through our providers, most of our community mental health centers, CCBHOs, our health home providers, FQHCs also have healthcare homes. But because all of our partners in the behavioral health and SUD world are connected to the coalition, I would imagine that we could probably have a conversation with the Missouri coalition that, I forget their name, but the Behavioral Health Coalition.
Yeah.
That's statewide, that could probably help share a little bit more of the back end stuff with us. So we could probably set that up, and as long as our members agree to request that, I'm sure we could reach out to them, since we're trying to make some inroads with this in the region.
Yeah, and that's a great, thank you, Wendy. That's a great point. And they've been open, even as an out of state entity looking for information, they've been really open and supportive and showing the functionality. But here, I think we have a potentially interesting use case, just to understand what can be shared, how can it be shared, what are the possibilities of linking to the platform. So many of you, thank you for everyone for putting in the health home providers on here. Does anyone want to, while we're here, I'll give another minute or so, and if you're not prepared to do so, it's not a big deal. Does anyone want to share their experience working with the Care Manager platform? It seems to be pretty innovative. Again, I know it's not perfect, but if you think that there's a potential there, we'd love to hear your thoughts. If not, we can move on to the next topic. If anybody wanted to share that, I know that's part and parcel being part of the program, and we had referenced it in our kind of national scan. So if there's no volunteers, we can certainly move on and certainly follow up on health home and Care Manager integration and functionality. Okay. Melissa, you can go ahead and advance to the next one. Okay, Sally, I know we're going to use this space for an update around hospital-specific alerting. So I don't know if you want to walk us through here the two kind of, I'm going to call them sister programs, but parallel programs that are running. So ERE and EPIC.
Sure.
Hospital. We'd love to hear this. Go ahead.
Great. So I'll do the second first. Is with Barnes Jewish Hospitals. They're one of the highest referrers to the EPIC program, which has recovery coaches respond to patients who present in an emergency room after an opioid use incident, usually an overdose. And they built into their electronic record system a triage screener. When the question set says, if the patient is positive for opioid use, then an option appears to refer the client to EPIC. And I think you click a button, and then an administrator makes the call to try and get a recovery coach to come out. And it's been wonderful. And I think that they need to also indicate, perhaps why they did not refer a recovery coach to outreach the patient. But that is, an element of using IT where it's a behavior trigger to a hospital staff. Similarly to that, Mercy, this is very new. we ran a report of 150 patients they had referred to the Emergency Room Enhancement Initiative in the last 6 months. These patients are high utilizers of hospital, at least 3 encounters in the last 3 months or 6 encounters in the last year. And in the course of delivering care, it occurred to one of the hospital staff providers to refer to ERE. And after the referral, we ran that report and we have fed it back. They have a hub where behavioral health assessors are tapped if, say, I'm a patient, Sally, I present at Mercy St. Louis and I have a behavioral health need, then the ER colleagues would call the hub to have a face-to-face or a virtual behavioral health assessor to work with me. And in the alerting structure, when they pull up my EMR, we are putting a flag in saying, this person is ERE referred, and in a note, some very few words about what to know about me. It's really just a sentence. And this is the community clinician who is engaged in my care, who should be called if and when I represent. So we've been working on that, and it should go live any day. And again, it's taking the structure we have where outside of the Mercy system, we ran a report of who's been referred, and they manually typed the alert into the patient's EMR. Now, the third kind of pilot that we're doing with Mercy is increasingly working in, they have approved read-only access for the BEACN facilitated outreach efforts. All those outreach staff, the masters and bachelor's prepared clinicians to have read-only access to Mercy's EMR. And increasingly, we are doing collaborative case staffings for very challenging discharge planning, and case notes are going into those records. And we're just a couple weeks in where we are identifying emergency room enhancement patients who are high utilizers, and the outreach team has really struggled to succeed with these patients. So we're doing preemptive complex case staffings and putting those care plan notes into the patient's EMR. And with read-only access for the community providers, they can access that when they're interacting with the patient. So those have been the efforts in this realm that we've been launching in the last, the EPIC one is, I think, about 9 months old, and the other things are happening right now and in the midst of going live. I know I got Patty Morrow here and some other Mercy colleagues. Anybody, and if I'm not sure if we've got somebody from Barnes, anybody want to add or to my description of those efforts?
Yeah, this is Dr. John. I think you did a pretty good job of describing it. I'm not as familiar with the ERE program, although I sat in on a staffing today, which was very interesting. But I think you did a good job of summarizing from a Mercy perspective.
I'm very, very hopeful about what these collaborations can do to make it, to have the hospitals and the existing outreach staff work in more intimate partnership on behalf of the clients. So that's what we've got so far. Jason, I think back to you.
Sure, that's helpful. And Sally, we can dig deeper into that to get some of the more those specific details. So thank you for the overview. So it begs the question in the context of Project BEACN, right? What is planning for alerting, again, across the 3 systems, especially the health systems that we're talking about here? It sounds like you can build off of some of what's already been built here. But we really like to hear, Sally, from you and from maybe some of the system players here about, you know, we have another use case, right? Or we have another program that's going to require alerting. Now, I can see on ERE, you're saying you can essentially, an alert can be triggered by a certain clinical outcome. So I'm wondering what the plan is around alerting around Project BEACN, whether it's for project eligibility, if someone that's in the program enters into a system, like what's the vision around kind of like individual alerting in health and hospital systems, and then potentially even collective alerting. And we'll get into more of the collective alerting across systems. But Sally, I'd love to hear your vision about that and how you're thinking.
Well, and we have an implementation work group, and there were a group of leaders who helped write this initial grant proposal. So the vision we articulated when we were writing the proposal and in discussions has been one, to be data driven in our identification of the most complex care cases. And the 3 hospital systems, SSM, Barnes, and Mercy, are at different points in the process of identifying which patients with mental health and substance use needs would they want to elevate to the status of being a BEACN patient, a super utilizer or complex care patient. And a lot of that, so setting of the criteria, whether it's cost or certain diagnoses or certain number of presentations at the hospital in a certain amount of time, they're in the midst of setting that. So data would be used to identify the eligible patients for the intervention, versus ERE and EPIC, which do amazing work, but they rely on hospital staff having it occur to them to make the referral. So the patient population selection is one thing. The other thing is these high utilizers of hospital, we would love a way where if a BEACN prioritized patient, because we did a lot of research in writing the proposal, and I think it was like 50 patients were the super utilizers in the Eastern region, and they're using multiple systems. So if there were eventually some way that anytime, say I, Sally Haywood, were one of those patients, anytime I present to one of the hospital systems, that there would be an alert to the outreach intervention team who could engage with me, and to the liaisons within the hospital who know about this complex initiative. Short of being able to do it with multiple provider systems, we were hoping to do an alerting structure first as a first entree within each of the 3 hospital systems for their prioritized patients. And that's where we started with the experiment with putting a flag in Mercy's EMR for the patients they've already identified through ERE. Did that?
Yeah, no, that's a really good overview. And it sounds like
okay.
One, focusing on obviously setting a criteria. Who is, as you start to stratify, like who are the individuals, right? What is going to be the triggering criteria? So having the data to do that, then individually prioritizing across each system. And what else is coming up for me? Yeah, and I think as we get into the next couple of slides here, we'll talk about like that collective piece, which is obviously, higher developmental step in the program. And then, so also it begs the question as well, that if you're identifying folks and you have a list of folks ahead of time, right? We're talking about in-house hospital alerting. These folks are circulating in the community and are having touch points with our community providers, right? So there is the opportunity to potentially, and I know we're using inpatient utilization as a potential trigger, but there is the potential of identifying somebody before they get in-house and having a plan already set up for that, or a proactive outreach plan before they readmit. So it can just play into like kind of the clinical workflows as well as you start to identify people. All right. Well, thank you, Sally. I think this is really important, and it speaks to like building off the work that has already been done for some of these other programs, and using Project BEACN as a way to like kind of even further develop this. And I know Mercy has their own BEACN project, which is really going to accelerate work. And excited to see this, expanding at the two other health systems and finding ways to incorporate the community providers as well.
Jason, I forgot to brag on Barnes Hospital, and I don't believe we've got anybody from Barnes with us just now, but they have for a few years now implemented an initiative they called Familiar Faces. So they do, via a data pool, they identify their highest utilizers of care. And about a year ago, they started including the regional coordinator of the emergency room enhancement to their monthly meetings to do proactive care planning. And then those who do not have behavioral health, but they're expensive or frequent utilizers of the hospital for other physical health needs, then she would dismiss herself and they would carry on. So behavioral health was not a prioritized diagnosis in their Familiar Faces initiative, but it's extremely comorbid with a lot of their highest utilizers. And the ERE leadership have been partnering with them on that work, where they run a roster, have a multidisciplinary Barnes system team, plus one social worker from outside of the system, come up with a care plan, document it in Barnes EMR, and then collaborate on implementing it. So that's another inroad that we're trying to deepen.
That's excellent. And Jason, there's a question from Barb.
Yeah, I love her question. I was just going to bring it up, and I think it ties into the slide. Lauren, do you want to take that? Or I'm glad to.
Barb, would you mind explaining a little bit more about your question? We'd love to talk about that.
Sure. Sometimes systems are so impermeable to talk to each other that we still want to be able to share important information with each other. And while we're trying to figure out how we can do that, or instead of perhaps a dashboard or this preemptive plan can be constructed and sort of follow the person, and that person can sign releases that we can talk to each other, et cetera, and possibly do it that way. Again, I don't know if that's too off topic or takes us too far away from what is. I just was not wanting to lose the opportunity to share information because I really like the way this direction's going, and didn't know if it could follow an individual as opposed to one of the health systems.
It definitely can. And that's where the work gets really exciting. So some of the communities we work with have a shared consent agreement that the person signs. And the community as a whole, including the police and EMS and fire and multiple agencies, do a case conference across the community to develop a shared plan of care. So you can do that with an alert. You also, as care coordinators who are intersecting with this same person, you can talk to each other. That is allowed from HIPAA because you're trying to improve coordination of care. The dashboard across the city is really exciting. The collective medical kind of functions like that if you end up using it. Like everybody can see it. You can add into the care plans in there. It alerts you. It shows you the person's history, and it shows you who's involved as part of their care team. You can look at data as a community. So you've mentioned several programs that have really great data analysis going on. So Mercy's and Barnes Jewish with the Familiar Faces, and SSM has talked about some of the work that they're doing. But if you looked at the city data, it'd be really interesting, like you did when you found those 50 people who are super utilizers across the city. If you look at this as a community issue and a community opportunity, there's tremendous gain you can get from doing that. You start to see all the different systems a person's intersecting and the potential that can come from collaborating, connecting that story, connecting the resources, and the efficiency that happens from that. So definitely. definitely.
Mhm.
So did you want to comment on that?
I think Barbara brings up a really good point, right? And it talks about it and centering the needs of an individual here. We're living in, there's so many systems, fractured systems here, so many silos, and a lot of potential, right? We're talking about, oh, how do we foster interoperability here? And a lot of times, and Lauren, you mentioned this, especially when you're starting with a smaller pilot. Project BEACN is not intended for everybody with a behavioral health diagnosis in a greater state. It's a very focused project and you can wrap your head around 50 people, right? And beginning to learn and build something from there. So I think we're gonna have to think about solutions that can be used initially to help foster that. We're gonna talk more about some of the functionality of collective medical. It's kind of what it was designed to do, cut across organizations and platforms on a unified platform that you can build, that you can populate with a certain population, for example, like these 50 individuals, and start to build data sets around them and start to populate that with different inputs from health systems, community providers, and enrich it with other data. I think that's, that's definitely one of the goals here is how do we find a way to collectively work on behalf of this individual, right, or along with this individual. So thank you, Barbara, for that. I think we're best to kind of keep our vision on that. Like, how do we get to that and work to try to break down these silos? With that in mind, a couple of other questions before we get into kind of the meatier discussion around collective alerting and shared care planning. Sally, you mentioned this before, but I want to make sure we have some community providers here as well. We want to talk about so the folks that are participating on the call, and Melissa, I know you have some notes that you're taking and you might want to share your screen as well. The idea of accessing hospital records for a community provider is a really exciting thing and can potentially really useful, but there's a lot of barriers sometimes in getting that done. It sounds like there's a group here that there is some established connectivity. So I know we wanted to get right into it as far as the community providers that are on the call. Do you have access to the local health system's electronic health record, whether it's read only or some folks can actually write a note if they're credentialed as well to foster that type of kind of clinical integration. So if you could, and Melissa, I know you have a schematic, you have a grid that you want to fill out. Maybe if you want to share that, we can go through organization, the folks that are being represented to make sure that we're incorporating everybody here. So I'm not sure if you have representation, but as we can see here, Melissa, I'll let you go ahead and walk everybody through it.
All right, thank you, Jason. Okay, so I know I've been working very closely with all of the CMHCSU providers on getting Mercy access so we can kind of bypass the Mercy column, because I believe I have everybody's. I received the last one I was waiting on today, so that'll be submitted to get the read-only access from Mercy side. However, I know we have this chart, and you guys can tell me if it's right or wrong. Does this look correct, besides the Mercy column, on whom has access to what hospital system?
And Melissa, there's a question in the chat. When you say access, are you talking about Epic Care Link?
Yeah, Epic Care Link is the kind of remote access that you can use for the organizations that are on Epic. So yes, that would be the example where you could do all the different encounters that the health system is having.
Yeah, it's basically like read-only access. I know for Mercy, for instance, they will typically have a link that they can log into. So yeah, it would probably be the Epic Care link. So.
Thank you, Karen, for that question.
Okay, so how about, do we have, I know we have Lauren on from Compass. So Lauren, is that correct? You have access to Mercy, Barnes, and SSM?
I don't think we have access to Barnes, but Mercy and SSM, yes.
Okay. You said you don't think you have SSM?
No, we do have SSM. Barnes we don't have access to, I believe.
Okay. And then, is there anybody on the call from, I'm sorry, I don't have my list up, I can't see everything at once. For BJC Behavioral Health, do you guys only have Barnes, or do you have Mercy, or you'll be getting Mercy, but SSM?
Hi, this is Margot. We have well, or it's in process, Mercy read only. I don't know that we have SSM.
Okay.
Can I follow? Oh, sorry. I just want to ask Margot while you're there. And while we're on, Margot, can you hear me?
Yes, I'm sorry. Yes.
So just because it's great to have a health system rep there, and going back the other way, do you have any access to community behavioral health providers' electronic health records? As I'm sure you know, sometimes it's like a black box, right, from a health system perspective. Into a group yesterday that had access. Just curious. Right.
So, so no, not as a BJC Behavioral Health itself, but as a part of the Missouri Coalition, for instance, we do, there is Care Manager, and that information, and then through DMH, then there's connection, but it's at an aggregate level, not at a client level data. And then there's some that also comes through, like for the ERE HCL, for instance. But again, that is for some of the people in the programs, they utilize that access, but as a system or an agency, it's not anything more than just aggregate data. Did that help?
Yep, thanks for that. And I'm recollecting here, and thank you for Wendy for reminding me. Your operation is a community mental health center. I was associating that with one of the health systems.
Yes. Sorry.
Yeah.
So there's BJH and then behavioral health.
What I was getting at broadly is we're talking about community-based organizations, and I'm going to let you go through it, Melissa, go through everybody, having access to hospitals data, but also thinking about, do hospitals have access to the rich community mental health data that's out there? And oftentimes, and this is coming from working in a community mental health perspective, like we're seen as a black box. We don't know, like there's not that interconnectivity. So we can save that till after we go through this assessment, but it'd be interesting to hear from any health systems if there is that.
I think you can generally say no, that the hospitals cannot see any of the data that is generated by the community providers.
Thanks, Sally.
That's correct, Sally. We can't see it at SSM.
Okay. Well, thank you thanks for sharing, everyone, with that. Does this, if I could just get those, if this is correct or wrong, or if something doesn't look right, would you please just let me know? You can put it in the chat if you'd like, or you can hop on and let me know. All right.
Good comment, Karen. And speaking to the silos, right? There's really good work going on, right, across the continuum of care here, and across sectors, right, from behavioral health to physical health, and especially if we think about the individuals that we're targeting for Project BEACN, not having figuring out a way to have these inputs, because we need that 360 view, right? So this is what this assessment is getting at. I'm glad we're uncovering this, and this is not uncommon, and they're certainly not insurmountable, as Lauren had mentioned. But we have clinical work happening in different organizations, and in order to really deeply collaborate and integrate that, we're going to have to think creatively how we're going to do it. So Melissa, I'm guessing we'll pause here, and you're going to clarify on who has access to what. Thanks, Karen. And speaks to Barbara's point about and where the technology is leading us as we get into the next couple of slides on having a place where we can actually begin to integrate care. And certainly starting a pilot, that can certainly start as a manual process, but leveraging the technology that is out there to begin this. And using these complex care programs as the initial disruptors and innovators to get that going. So I think the last question here is really going to focus on, which health systems are we focusing on with Project BEACN? Who are the community providers that are associated with that? And that would better inform that way this last question. Melissa, I'm okay to go on to the next slide as we get into more of the discussion around collective learning and shared care planning. I'll start us off, and I think, and Lauren wants to work us through this as well. As far as the health systems that are on, and this is just to confirm, but I also want to hear from the community mental health providers. Could you chat what EMR vendor, what organization you're with, and which EMR vendor you have, so we can get a quick scan of the terrain. So if you're with we've heard through Melissa and the team at BHN that most of the health systems are on Epic, which is great. Yeah. So a question for the SSM individual that, thank you for adding that in. Can you just describe, are there across the system, are those multiple different instances of Epic? Is it?
No, we're all in one instance now. We've converted to one instance.
Great. And it'd be interesting to hear to get that from Mercy and Barnes as well. And that's from a technical perspective, that presents some opportunities, right? So, but that's not necessarily the case across all systems.
Right. Well, it wasn't the case for us until fairly recently, because St. Louis University Hospital, which became part of SSM 5 years ago, they were on a separate instance for, just until about 6 months ago, maybe. Mm-hmm. And, but yeah, now we're all in one instance.
So just clinically, could you just describe to the group what that means? So for example, if I write a note, right, and I'm on a different instance on somebody, I may not actually see that note if I'm in another hospital in another instance. But if we're in one instance and there's one medical record number, that's a unified record.
Right. Right.
Things, but
would you, for others' edification, would you describe Epic instance?
So this is Karen Bradshaw with the IHN, and I happen to have Epic access in all three, and I would systems, and all three are instant systems. So you can see, so for Mercy, you have the ability to see, or at least regionally instant, not like whole system instant, but regionally instant. For Mercy, you're able to see encounters at all the regional clinics, outpatient visits, all three hospitals in the region. In that person's chart is a single chart per person for the whole that instance. SSM, like Michelle said, SLU being incorporated, it's with all the other hospitals in SSM St. Louis, and BJC. You also have the ability. I saw BJH was listed, but BJC's Epic, you can see all the different hospital encounters as well.
So, Sally, what we mean by instance is sometimes just use instance. Some people use org. But if you are not on the same instant, then you aren't really necessarily connected. Okay, it is a way of connecting. And so, for instance, SLU for us was the biggest example, although Wisconsin was the same. They were on a separate one. So right here in our own community, if a patient went into St. Louis University Hospital or had follow-up appointments or had other things, we had to go through roundabout and different ways to try to pull that information in. It wasn't all unified in one record for the patient. Now, being on one instance, it is all unified.
Good.
Thanks, Michelle. Yeah, so essentially, imagine having a separate chart. If you're on different instances, right, you have a separate chart at each hospital within the same system. And I've worked directly in systems where we had that. We had a different chart for the same individual at multiple different hospitals, and the systems really didn't communicate with each other. This unifies that into one single chart for an individual. Imagine it under an individual medical record number across multiple hospitals. And many times that can include outpatient ambulatory services as well. Just depends on how far that instance goes. So the fact that you have 3 main health systems each on individual kind of regional instances of the same electronic health record, Epic, presents a really unique opportunity here to think about integration from the health system perspective, but then also a place to link into from a community provider perspective as well. So thank you for that. And I just want to, the individual who said that you have access to all 3 health systems individual instances, I just want to make sure I noted your name, because I think that's a pretty powerful kind of perspective to be in.
So my name is Karen Bradshaw. I work with an organization called the St. Louis Integrated Health Network, and I'm the director of a program called the Community Referral Coordinator Program. That program contracts with all 3 hospital systems and 9 specific hospitals. So we have staff at all those hospitals, and because at one time I supervised all of them and I've worked in all of them, I have access at all of them.
Great. Thank you for that, Karen. Very powerful spot to be in, to be able to toggle between those systems. And especially with like a population like this, that's not unheard of, that there's a central person that has that accountability, that is able to go through to.
Yeah, I don't have remote, so that's why I asked before. So there's a difference between having remote Epic access and Epicare Link. Of course, Epicare Link is that read only. I don't sit in one spot and where I could log into all 3 at the same time. I have access for most of them where I have access on site if I'm covering for someone who's a staff person in the emergency room or inpatient units. I can't sit at one desk and pull up all 3. I don't have that ability.
Yeah.
The other piece, just so you know, that at least the 3 hospital systems have within Epic is Epicare Everywhere. And that is a toggle within their Epic where they do, within the hospitals, have the abilities to see some hospital data from the other systems. So if somebody presents to Mercy's ER, for example, at Mercy St. Louis, if the provider clicks on Epicare Everywhere, can see if that person was recently also at DePaul or Barnes or any of the above, and they can see some clinical info there. But that's as much as I know that the 3 communicate with each other.
That's really helpful. Thank you, Karen. We had referenced Care Everywhere before. And if you happen to know, we're going to ask the question about Healthy Planet, which is more of a population health and ACO management tool. But there's the potential there already through Care Everywhere. Again, there's already interoperability. Again, maybe it's very light between the systems. So again, some opportunity. So I appreciate that. I know we have about less than 15 minutes. We have some other technical items to get into. Lauren, did you want to start walking them through here?
We're going to do a rapid round of chatting, typing in the chat. So I am curious if you, everybody from the hospital systems, can you quickly type into the chat, are you using Epic Healthy Planet? This will help us to know about possibilities going forward.
And Lauren, Melissa and I will take these questions to Barnes subsequently. So we'll get a rounded system response to these questions.
Right.
Gotcha. This is Healthy Planet is an add-on. It's something that not every Epic organization that's using Epic uses. But it's here again. I'm encouraged to hear about the Care Everywhere. Although admittedly I haven't. It'd be good to see it in action and learn more about that.
And then what we would love to know is there one person from your organization that would be the key contact for ongoing dialogue about IT design? So we have some questions on here about current reports you're doing, what your policies are about alerts, what kind of data analysis you're currently doing within your organization and across the city. But that's a lot more than we can get into in the next 5 minutes, even in the fastest finger typing you could ever do. So one thing we want to walk out of this meeting with is who from your organization would be the pivotal IT person for us to stay in contact with as this moves forward. So if you could each type your organization and that person in the chat, and it may be you. So, but we really want to walk away with this. And this doesn't mean you're signing up for hours and hours and hours of meetings. It just will help us to be very efficient as the design moves forward, to be talking to the right person and really getting your voice, your organization's best practice, the things that matter most to you integrated in this initiative. So if everybody could take a moment and write, who is their key IT contact? Thank you.
And Lauren, I'm thinking as folks are putting in there, and Melissa will be, and the folks at BHN will be following up just to make sure we have the right people at the table. We do have a little bit of time left, and I'm wondering if we have some specific questions here that I think we can hold on for now, Lauren, and maybe open it up to the group here as we've had this discussion and been talking about the trends. I love what Barbara was saying about, this is really a community design kind of challenge here across systems. What's coming up for you all? We don't want to miss that right now as we've juggled, there's a lot of ideas flowing. Please feel free to jump off of mute or to chat some ideas or some maybe there's an existing function or system that can be leveraged here that we're missing. Again, as Lauren was referencing, there's a unique opportunity here. There's really good alignment of leadership. There's good alignment even in the systems here. We think there's a lot of tools that can be brought to bear. I'd love to hear for your perspective. So if anybody wants to jump on and add a thought, a comment, question, please. Let's get the next slide probably. For adding these names.
Yes, I'm writing them down.
Great. So with the few minutes that we have left here, Lauren, before we kind of close out, are there any other, and we can certainly go back to some more of the technical questions, but kind of closing thoughts here, next steps to consider, how other communities, when they're at this point in their stage of development, it sounds like we've got a defined project, we're building out, there's great alignment, kind of, and we really wanted this to really be action oriented. We don't want more conversation, we want action to come out of this and starting to begin to execute on these goals, and we think there's a great opportunity here. Lauren, what do you see as the key next steps in order to begin to build an IT and data infrastructure around this program that'll best serve this program?
So I think a piece of it is individually will be Melissa or the team or us will be reaching out to you to get an inventory of what is going on now. The more we understand that, the more we will have a really effective solution that's co-designed in a way that works for you and captures your best practices. The next thing I think is a shared community-wide definition of the population and the preferred collaboration, integration of best practices, and the IT will come very quickly along with that. Understanding what you have now, what's working, and what can be integrated is really important. The more we work with your best practices now, the faster this will go and the deeper the implementation will be and the more successful it will be. One other contact that would be helpful for us to have would be to know, You know, any of these initiatives are only as successful as the support that you have from your CFO. And we're very interested from your organization, who is that key financial person, that financial voice, where we need to take into consideration the business model for your organization? Who might that person be at your organization? So if you could take a moment to type into the chat, who is your financial lead? That's really important for us to partner with for buy-in, so that we make sure that we're meeting what's most important to your organization. So if you could type your organization name and the finance contact, that would be really helpful for our next steps too.
Thanks, Lauren, for that. Yeah, and we have an upcoming financial discussion very similar to this coming up next week. So we're going to want to make sure that we're aligning, right? Those leaders.
So Sally, just as context, is our consultants, we had contracted for them to do a site visit, and they would have met with multiple groups. And we've reshaped it to be virtual. The kickoff we did last week, which we will resend that recording link. And then 4 subpopulation meetings. So this first one being IT, next being finance, and then on care coordination and collaborative staffing, and the last one on metrics, dashboards, things to track and evaluate. And of all this work, we hope to collaborate to serve vulnerable patients better, and over the course of the next couple of years, come up with a business case for supporting complex care and intensive outreach for the most vulnerable in an ongoing way. So asking those who are responsible for the financing and monitoring the kind of return on investment conversations that we'll need to be having, we want to make sure they're involved. So takes all players. So thanks. And from these site visits, Lauren and Jason will give us recommendations for our course of action for implementing complex care.
We want to thank you for taking time on your Friday afternoon. Your input, your contacts, your excellent work that you're doing is so helpful to see, and we really look forward to partnering with you in this initiative. It's incredibly innovative what you're doing in St. Louis and what you're looking at doing next. We have the opportunity of seeing a window around the country of what communities are bringing forward. And COVID has highlighted the need for these kind of integrated networks and collaborations across systems. And we're really honored to be working with you. So we will definitely say to be continued, and release you to have a fantastic weekend. You can look forward to additional material and follow up from us coming soon. We want to thank you so much for joining us today.
Thanks, everybody. I'm going to have a nice weekend and stay safe, and we'll be in touch.
Thank you.